Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today we have Dr. Paul Pepe, an emergency physician and highly recognized expert in EMS, critical care, and resuscitation, along with Ryan Quinn, EMS Chief for Edina Fire Department in Edina, Minnesota, joining us to discuss a significant advance in resuscitation for patients with non-shockable rhythms and cardiac arrest with a remarkable increase in neurologically intact survival. Welcome, gentlemen. Dr. Pepe, I'd like to start off by thanking you for taking time to join us to discuss this concept of head up, or what you now refer to as a neuroprotective CPR bundle. First of all, can you define what this entails and why is it referred to as this neuroprotective CPR bundle?
CPR has been life-saving for 60 years the way we've performed it, but probably only in a very small percentage of cases. And that's one of the problems. We have almost 1,000 people a day who have sudden cardiac arrest out in the community alone, more in the hospital. We know that like early defibrillation and early CPR can contribute, but it's still a small percentage of those. 75 to 85% of the cases that we go out to see will have non-shockable rhythms and flatlines, and then some cases are what we call, I don't know if it's a misnomer, pulseless electrical activity, meaning that there's some kind of organized complex that looks like, but there's no pulses associated with it. And so that's why it's a problem, because one, they don't come back. Part of the reason why we see poor outcomes is not just that these cases tend to be people who were in ventricular fibrillation and then just went on over time and were not witnessed or not resuscitated or had a long response time, and then they basically either go into flatline or auto convert into these sort of bizarre rhythms. So that's one of the problems. But the other issue is actually, quite frankly, the way we perform CPR. CPR has been life-saving, but it only generates about 20%, maybe 15% in some cases, of normal blood flow, and particularly cerebral perfusion pressure. And we've looked at this nicely in the laboratory. For example, if you're doing chest compressions, sort of the turkey baster thing, in a sense, we're doing on the chest, we're hoping during the recoil phase to pull blood, down and back into the right heart. But the problem is that you're not only setting a pressure wave up here to the arterial side, you're also setting back pressure wave on the venous side. And so what happens is, obviously the arterial side always wins out, but it's just not as efficient as it could be, 20, 30%. What does this entail? Well, it entails several mechanisms that have independent mechanisms in terms of how they work, but they all do the same thing, which is they help to pull blood out of the brain and back into the right heart, okay, by basically manipulating intrathoracic pressure and creating more of a vacuum to get blood back there. So important that people do quality CPR, by the way, let alone what we're going to talk about. But you have to have a good release, and that helps to suck, as we do, suck a little bit of blood and sucks air in. But as soon as the air rushes in, it neutralizes the pressure. There's no more vacuum, and nothing else is happening until the next squeeze. What we have found is that we could cap the airway just for a second with a little valve, a little pop-off valve. It kind of acts like when you're sucking through a straw, with a milkshake, and it creates more vacuum in the chest. So there's a little pop-off valve that pulls a little bit more blood out of the brain and the rest of the body, and then into the right heart. So that's one part you can put on. We've actually shown in human studies that the blood pressure, for example, systolic, goes almost quadruplets with it. It really goes from like 20 millimeters of mercury during standard CPR up to 80, and that would be sustained, for 14, 15 minutes. That was a nice little study that was done out in Milwaukee a few years ago. The other thing that happens is, now if you add on something else, it's like a toilet plunger, and I think many people have seen it. It's called active compression decompression. Not only compressive, then it decompresses. And where it becomes even more effective is that if you had broken bones or stiff bones, as you get older or whatever it may be, as you do the CPR, you're still getting the push down, and then you're getting the pull out. So it's kind of helps on several levels. But more importantly, when you put the two together, they're very synergistic. We, in a sense, have already done the clinical trial that is the proof of concept. And that was published in the Lancet about 10 years ago. And in that study, we found that the combination of those two improved survival rates 50%. I mean, it went dramatically, with 1 year survival neurologically intact. So that got us on the right track. But the interesting thing is that someone said, can we lift the head up a little bit? And so we did a lot of work in the laboratory over 10 years, fine tuning it. When do you first lifting the head? How soon is too soon? How because it's probably bad for you. Just went right to it. We also had to say that you had to get the pump primed a little bit with these other things to get the flow going better, not only pulling blood out of the brain, but now you have a better flow this way. So you got to prime it first for a couple of minutes. And we worked on the timing. Is it 3 minutes, 4 minutes? But it seems to be really right about 2 minutes. Then you gradually elevate the head over about 2 minutes. And what we're finding is that that seems to be the optimal way to do it. It's about 2 minutes of priming with those other two devices, the adjuncts, and then gradually elevate the head over 2 minutes. And when we do that in the laboratory, we're getting normalized cerebral perfusion pressures. And so you're normalizing the flow back again with that. So it's profound. And so what we're seeing is profound differences in outcome as a result, even in these cases of the non-shockables.
So what you're doing basically is resulting in increase in cardiac output, essentially, and that really is important, especially in these non-shockable rhythms. Is that correct?
Oh, absolutely. And then the other thing is, as you're doing this compression and you're getting these intracranial pulse waves that are going up because they're colliding up there, right? And so it could be even damaging itself. I'm just saying, but we're seeing these intracranial raises, and they actually the intracranial pressure starts going up more and more over time. And also peripherally, in most people, if you're not getting good flow out there, then your vasculature starts to relax. The arterioles are starting to not get oxygen, so they don't go out. With this thing, where we're returning the pressure, especially we're getting 40% of normal now with the ACD, ITD approach. And now you add this in and you're almost normalizing. And I'll tell you what, in humans, we're seeing even in these asystole patients, we're seeing end tidal CO2s, which are generally in the 15 to 20 range with standard CPR, are now been up with the ACD, ITD in the 30, 40% range. We're getting through 30 to 40 end tidal CO2s. Now we're seeing even the end tidal CO2s moving up into the 40s and 50s. So we know there's a surrogate marker telling us that we are generating much better flows, not only to the rest of the body, but most importantly to the brain.
I want to bring Ryan into this. Ryan, you could tell us about the approach in terms of on scene, what you're doing, and how you use the device itself. Maybe you could talk about the backpack that you developed with your fire department.
Our approach has always kind of been to get to the patient quickly, like everybody's approach on a cardiac arrest when you're responding. Um, we are a advanced life support paramedic ambulance service through the fire department. We're all cross-trained firefighter paramedics. Our first vehicle there from the fire department is typically the ambulance. It's smaller, it's a little quicker than the engine. Those two paramedics are going to jump out with two backpacks. One is the automated compressive device. We use the Lucas, and the other one is the sequential patient lifting device, the Eligard. Our two paramedics are quick to the patient's side, and once they make contact with the patient, verify pulseless, it's cardiac arrest, they will unpack. One person will go right to compressions if there's nobody on compressions already. Sometimes we have a first responder police officer with an AED. But we go right to the patient's side, concentrate on compressions, and within 90 seconds to 2 minutes, we have our bags unpacked. We've got the devices turned on, patient lifted up, slid under the device, and we've got a supraglottic airway that is placed within 15 seconds, already pre-made with the ITD on top. So we've got a sealed airway that we can continue to compress with Dr. Pepe's original kind of discussion of that, building on what's previously been shown to work. So within the first couple minutes.
Let me make a comment about this. This is so important what Ryan is saying, because it's something we found during the study. It's really a true pit crew approach. You're not only getting these materials, which you think you need a Sherpa for, but you don't. They set it up, and then when they open it up, it's there all laid out just exactly as you need it. It makes it true. So it's not just how fast you get there. It's actually how fast you get this done. And so let me tell you a piece of the data. When we looked at all cases combined against high performance systems that had some of the highest survival rates around, when we compared it to those, we found that overall, even if you looked at the ones that had over 20-minute responses, the odds ratios were still like 3 to 4 times higher. And so it was impressive. But if you looked at it under 15 minutes, which is really reasonable for most systems to get there. By the way, the average time that people start CPR in any system in these studies has been about 8 minutes. Okay. But if you actually start this thing, which takes about 2 minutes more, this new sort of, let's say, bundle of care, with this triad, what you're finding out is that it's almost like 12 to 14 times higher in terms of the odds ratio. I've never seen anything like that where the higher end is over 100. It's like in terms of your confidence intervals. Ryan's system did really well, and it's one of those ones at the even higher levels of outcomes, mostly because they got it on quickly. It's like the AED for non-shockables, but only better because you have a wider range of, let's say, a window of efficacy that it'll work. So very cool.
So when the elapsed time was less than 11 minutes, that seemed to be an inflection point in the study. Is that correct? So you saw an 11-fold higher incidence, or I guess in terms of survival, neurologically intact. Is that correct?
And we picked that number, by the way, because that was the median time to get it on board. So half the people were getting it within that period of time. The fact that you have a larger window, we're talking about now, 13, almost 14-fold improvements in outcome if it was under 15 minutes. It doesn't matter about the 11 or the 12 or what. It's like the faster you get it on board, the better off you are.
What's the next step in the process of doing trials and having implementation on a larger scale based on your animal study? Where do you go from here?
I've come to the point to find out there is a lot of so many confounding variables of what was the quality of CPR. How did people ventilate? Did they give the breath and hold it? Did they give a large enough breath so that blood can go across the transpulmonary system? So there's a lot of confounding variables there. But that's why I think in the future is going to be more in terms of looking at things like propensity score matching. And in this, because we know all the variables that change outcomes, I think that's going to be a way for me. But the other thing is that we only were looking at 380 cases here. So, when this doubles up in numbers as we accrue more cases around the country of people that are implementing this, these numbers I just quoted you are going to go much higher. Can you think about unwitnessed asystole is considered, futile by everybody. You just don't get that. But to be able to get these folks back now, even if it's a small percentage, it still says a lot. And the fact that we know that we're producing this better flow is pretty striking. I'm really impressed. And I think the main thing is to make sure people are educated about it. Number two is that they understand that it's got to be done right. It cannot be done wrong, or you're not going to see the differences. And getting it done right is not only following the procedures, the sequence, and how you do it, but it also has to do with getting there quickly. So assigning the right people to put it on and all that, and well-trained people that know what they're doing.
Right. And I think in general, the lay public obviously should not attempt this in the field to lift someone's head up, in the sense of trying to do chest compressions. And I think that message is important that you just said. It's not ready for prime time yet in any way. It has to be done right.
Bystanders have to learn CPR, and they will buy us time and will have better outcomes when they do that. That's number one. And then number two is that I think that as more and more systems adopt this, you're going to see more people coming back. I mean, if you think about what we're doing now, if we only get back 5% of these non-shockables versus less than 1%, it's 5% of 800 people a day, because 1,000 people a day die. Several dozens of lives can be saved on a daily basis, coming back neurologically intact. And that's the key thing.
Absolutely. Ryan, would you want to comment about your experience in the field, and is there anything in terms of your approach currently that you think would be ideal to change at this point?
We've established that this is the approach that we want to take, and we're just fine tuning to be more efficient. So using the choreography of which person is going to do which role. So clearly defined roles, clearly defined command of the scene. So we're not missing anything. So that part with training, with anything else, is extremely important.
Got it. And Paul, I want to ask you about, your anecdotal experience, and obviously with Ryan too. People waking up quickly and talking after elevating their head and going through this series of this whole process, and that having people talk about it and waking up is really, fascinating to me. Maybe you can comment further on this.
Actually, that's a great point that you bring up, because one of the guys we saved, he's like, I don't know, 40 or 50-year-old guy. that got saved with this approach. So when he came around, he said he was hearing what people were saying, and he came out of it. He found out he had been getting CPR for about 25 minutes because he had refractory, persistently recurring ventricular fibrillation. So he said, "How could I have survived that long?" And then we told him about the new approach. He goes, "Well, that's like neuroprotective." He's right. When you think about it, in the laboratory, we showed it was neuroprotective, and then also we're getting better flows back there. So it goes along with everything else. So we've adopted the name because it is. These were really high-powered systems we were compared against, and we had the same level of return of spontaneous circulation almost. They were kind of matched, but the major difference was when you started talking about the neural intact survival. We don't have enough numbers yet, but I'm going to next go around. We're going to look at CPC1 versus CPC2, which are both considered intact, but CPC1 is actually better. We're seeing much more of those, in my opinion, anecdotally. So I wanted to mention is that people do bring up this thing, well, let's do a trial. Well, as far as we're concerned, the trial's been done in terms of the Lancet study in 10 years ago that showed that the active compression decompression had tremendously better outcomes. And what we show in the laboratories, okay, augment that a little bit. These are all FDA approved. You can go out and buy it tomorrow and get it done. And I have no conflicts of interest, by the way, with any of this. To have this that's going to affect so many lives, or the potential of saving so many more lives, is really an exciting breakthrough. But more importantly, we're understanding now more about the physiology of CPR, and that we know why it kind of works, but it could be work much better with the approaches that we've been developing over the last 20 years or so, actually.
Absolutely. I want to thank both of you gentlemen. This has been really an incredible experience to learn more about an advance in resuscitation that could really, truly be life-saving. Thank you again for taking time to join us.